I'm a great admirer of Dr. Suga Sanji's surgical skills. But his talk on clear lens extraction is a surprise to me. Anyhow, my concerns of ICL are based on anatomical, surgical, economical, and risk versus benefit. Anatomical. The posterior chamber is not like anterior chamber. The volume is only 65 microliters. On a cut section, it is a triangular structure with a base pointing towards the ciliary process. So the apex is at the pupillary point, wherein the maximum size of the ICL is placed. And the structures coming in contact with the ICL, the ciliary process, it rests on that, only by that it walks forward. So it is always in touch, and you are going to place that lens on a 20-year-old boy or a girl. In the remaining period of their life, it is going to press on that. And what about the posterior surface of the iris? They will be released. And the effect of age. Only the posterior chamber is not a stationary one. As you age, the lens becomes thicker, and the anterior chamber gets reduced by 7% every decade. So both sides are going to be compressed, and the posterior chamber is going to be narrowed like a slit. So this is where we are going to place implantable contact lenses. The next is surgery. Any skill for that matter. Only when you practice over a period regularly with passion, you can master. And in the ICL, the lens design is changing, and you have a very low one. You don't operate every day. And the cost is phenomenal, and the patient's expectation. You can see those patients, the parents there, they expect you to do something good, and you are not sure about your own skill, and you are not sure about the long-term data, and do you really want to do that? Finally, economical. The cost is phenomenal. Not everybody can afford that. And those who afford, they have a high expectation, and they will take you to task if you don't perform well. Remember that. Finally, the risk versus benefit. This is the latest article I got, even though we have a lot of articles. I took this because of the 15-year follow-up. See that 15% of the people had IOP elevation, 38% had cataract, 3% uveitis, 36% ovalization of the people, and 30% IOL explantation. You really want to do that? So when I looked at it, then I wanted to have a reliable source, what I can tell the patient or what I can gain. And I got a very reputable source, and the first word they say about risk on ICL is, you may lose vision. I don't think any other condition in eye that we say, first thing, you may lose vision. Yes, in cataract surgery, people can lose vision, but we don't tell it the first. But here, that source gives us a lose vision. What are the other things? Debilitating visual symptoms, re-surgery, undertreated or overtreated, cornea can become cloudy, development of cataract and detachment, and long-term data is not available. And who gave this source? FDA. Remember, it is at fda.gov, you can go and check. So the same thing, why I prefer clear lens extraction, the same thing, anatomical. What other place can you place a lens except in the back? It's a natural process. And surgical, day in and day out, we do that. And it's not difficult to master in the myopia. And economical, you know that. Finally, the risk and versus benefit. What are the things that we can lose in a young patient when we operate in a clear lens section? Loss of accommodation, retinal detachment, and posterior opacification. But improved surgical technique, accurate biometry, excellent IOLs coming in, and the surgeons sitting, retinal surgeons, they can do anything, and they have excellent results. What else you want? So friends, what is needed is not all things new are good. What we require is a change in mindset. I graduated in 1986. At that time, we were doing intracapsular. When we go out to the screening camp, we were asked to select patients 1/60 are mature cataract because the safety was not there. But now you know the results. So the same thing now, presbyopic age, people are opting for multifocal IOLs, accommodative IOLs. The same thing, why not we do it for a clear lens section? Not for all myopes, I am suggesting clear lens section. Only for people who really need it, deserve it, after selection, this is the safest rather than IOL. ICL, sorry. Thank you.
Dr. Suhas, when you spoke, I thought ICL was fantastic. When he speaks, I think, oh, what is this? I seem to like what Paneer says. Yes, defend yourself, please.
Well, when you compare techniques, you don't really take cost into consideration. Now, cost, here we are talking scientifically about two techniques compared. And the results that he speaks of for 15 years study. See, that was a time...
The complication rate was almost 130%, 15 years, more than 100% easily.
So that was the time when this technique was evolving. If you take last 5 to 7 years, and especially if you take last 2-3 years, when the lens has evolved, it's definitely much. See, he's talking about the ovalization of pupil and explantation. Now, most of us who are practicing ICL here, I'm sure they'll say these are very absurd figures, because that's not the kind of complication that we get today. Because, see, with evolving technology, all these days we were really worried about actual sizing. And today with different machines, we can have a perfect sizing. In fact, now